Hello, and welcome to our presentation titled Big Vessels Are in Big Trouble with Takayasu Arteritis. This is brought to you by Dr. Fadi Boda, second-year internal medicine resident, myself, Parker Hughes, third-year medical student, and our attending physicians, Dr. Sanghera and Dr. Wilson. Together we represent the Abrazo Health Network Internal Medicine Residency Program and the Midwestern University Arizona College of Osteopathic Medicine. We're really excited to bring this case to you today, and hopefully we can learn something and apply this to our patients moving forward. Starting out with a brief introduction, for those of you who are not familiar with Takayasu arteritis, this is one of the two major vessel vasculitides, with giant cell arteritis being the other. Takayasu, it primarily targets the aorta and its major branches, and this is a condition that affects women in most of the cases. It will typically onset between 10 and 40 years of age, and it has its highest prevalence in those of Asian ancestry. Takayasu arteritis should be considered a rare disease, with frequency estimates being anywhere between 2 to 3 cases per year per 1 million people. While the precise etiology of this disorder is not yet understood, most of the current research seems to place an emphasis on interaction between both genetic and environmental factors. But again, the literature on this is quite nebulous, and we're probably still a little ways away from nailing down exactly where this is coming from. For a typical patient, the experience typically starts with an indolent disease course as the inflammation starts gradually, and what this is going to cause is some very nonspecific symptoms, and obviously this is not going to be inherent to what's causing them. However, with time this will progress to an occlusive state, and that's over a variable period of time, and the symptoms are going to occur at areas of the narrowed arteries. This can be anything from claudication to headaches, dizziness, or even abdominal or chest pain. Takayasu is a disease that has no cure, but it's best managed medically through the use of corticosteroids and other anti-inflammatories. So let's go ahead and jump into our case here. Again, really excited to bring this one to you. Our patient, she's a 31-year-old Hispanic female. She presents to the hospital with a 2-day history of acute pain in the bilateral lower abdominal quadrants. She reported increased pain with any sort of movement, and she further informed the hospitalist team that she's been very unsuccessful in managing this pain through use of Tylenol at home. Her past medical history is significant for chronic anemia and a Takayasu arteritis that was diagnosed at age 18 years. The patient informed us that her arteritis had been previously managed with both prednisone and methotrexate, but she stopped taking these medications about 8 years ago since she wasn't having any symptoms. Her physical examination was significant for variable blood pressures in each of her extremities and reduced pulses in the right upper and lower extremities. She further displayed abdominal and bilateral carotid bruits on examination. Her laboratories were significant for an elevated ESR and normocytic anemia. We'll get to her imaging in just a brief moment, but to highlight and pull out some of the key points, it should note that there were various locations of stenosis and thickening along the aorta and its major branches. Again, as previously described, this is very characteristic of the Takayasu arteritis. Our patient here, she was started on an oral corticosteroid therapy, and she was held overnight for observation. However, she needed to be later transferred to a larger medical center for both cardiothoracic surgery and rheumatology evaluation. So let's go ahead and turn our attention here to the center panel, where we have 3 key images from this case. Our first one here, we've got a CTA of the neck, and where I want us to primarily focus our attention is going to be at the carotid arteries. You can see here we've got the right one, and right here we have the left one. The right carotid artery, it features a thickening from its origin all the way to the carotid bifurcation. What this has caused essentially is a 50% stenosis of the vessel. Over on the left side, you'll appreciate that the proximal left carotid artery has a circumferential wall thickening along the proximal 5 centimeters of that particular artery. Looking down here at our second image, this is a CT of the abdomen, and again, this is a very interesting and in many ways a very beautiful image that highlights some of the physical exam findings we were talking about. Just from a 10,000 foot view, there's a really glaring abnormality right in the dead center of this image. Right here we have our aorta. And it doesn't take too much experience to realize that this is a very unusual appearance. There's a very blatant blatantly obvious change in diameter and in terms of the wall thickening. And in fact, on measurement, the abdominal aorta is at 18 millimeters proximally. It narrows to 10 millimeters just below the renal arteries, and then it measures back up to 15 millimeters proximal to the aortic bifurcation. So we see where that stenosis is occurring in the abdominal aorta. Our last image here, figure 3, this is very similar in terms of the relevant findings to the second figure, but I really like this one because it implements some newer technology. It's an MRA of the abdomen, and if you're looking at this on the computer, it's actually a three-dimensional reconstruction. Obviously, we can't toy with that feature here in the poster, but again, there's some very fascinating findings here. When you're looking at the proximal aorta and the distal aorta, these are both going to measure at about 16 millimeters with an area focal thickening at the mid-aorta, and that's going to measure at just under 7 millimeters in diameter. So again, really highlighting some of those features that are both typical of this disease, but were appreciated on the physical exam. So turning our attention to the discussion of this particular disorder, again, I want to highlight just how rare this condition is, and a successful diagnosis is going to require a clinician who is both suspect, number one, and number two, very careful in their workup of the patient. Because the early disease starts with such a nonspecific phase of the constitutional symptoms and that later progression, it's going to, again, require that careful workup. Our physical exam was very characteristic of Takayasu arteritis, and as we've kind of learned coming along here, it becomes very apparent during that occlusive phase of the disease. Takayasu has been nicknamed the, quote, pulseless disease because of the stenosis that occurs here, and the patient in our case displayed these classic signs and symptoms. Not only did she have the reduced pulses in the right extremities relative to the left, she also displayed differences of greater than 10 in terms of her systolic blood pressure between the arms. Again, that's another important classification item. Further, our patient had bruits at the carotids bilaterally and in the abdomen. And then the cherry on top, cardiac auscultation revealed a systolic murmur at the aortic post. We were already alluding a little bit to the treatment of this condition earlier and how that's built around a foundation of corticosteroids. But to be a little bit more specific, most physicians will start out with a very high dose of oral prednisone and taper that over time. Of course, any sort of steroid therapy, you need to be careful with the management just because of the myriad of side effects and long-term complications that can occur with steroid use. So obviously we're going to want to be mindful with that particular therapy. If your patient presents with a more aggressive case, you're going to want to consider a few other options. Number one, methotrexate. Very well studied, excellent medication for these types of patients, and even azithromycin can be indicated in certain cases. For those patients with the most insidious, most concerning cases, surgical revascularization may even be indicated. So to conclude our case here, again, we're happy to report the Takayasu case in a 31-year-old female, and this excavatration occurred secondary to her medication noncompliance. This encounter occurred while on a medicine rotation in August of 2020, and the reason I feel that this is very important for us as clinicians moving forward is because, number one, we have a rare condition, and number two, this is a condition that's going to require both lifelong assessment and treatment. So in this particular patient, it's going to be absolutely essential we reestablish care to manage her health and avoid not only symptoms but progression of her disease state. The authors here, we are really emphasizing the need for regular follow-up and education with those patients who suffer from Takayasu arteritis, just because of what the implications of this diagnosis means across the lifespan. Again, this has been a case on Takayasu arteritis. It is our pleasure to bring it to you today. We hope that you're able to pick up some key clinical points here, and thank you for your time.